We present our experience with robotic incision-less supra-levator posterior exenteration. The aim of this video is to emphasize on the standardized approach for complete splenic flexure mobilization by medial to lateral dissection, fluorescence-guided lymphadenectomy to improve lymph nodal harvest, emphasis on pelvic floor dissection, intracorporeal transection and anastomosis under fluorescence guidance, and finally transvaginal specimen extraction to avoid a utility incision. Our patient is a 66-year-old lady diagnosed with lower third rectal cancer starting 2 cm from the anal verge, status post-neoadjuvant chemoradiation with residual disease CT2N1 with negative CRM and an uninvolved sphincter complex. Port placement was done as illustrated. Peritumoral 3 ml ICG is administered under proctoscopic guidance to navigate the lymphatic channels in real time. The dissection is started by scoring the peritoneum below the inferior mesenteric vein and extending it craniocaudally from the inferior border of the pancreas to the origin of the left colic artery to work on a broad front. The dissection continues in the medial to lateral dissection along the mesocolic plane, safeguarding the nerve plexus, gonadal vein, and the mesocolic vessels. The lateral peritoneal attachments are incised, which marks the lateral limit of dissection. High ligation of IMV is performed and dissection continues along the ventral surface of the pancreas and the lesser sac is entered. Splenocolic and pancreaticocolic ligaments are divided conveniently by the medial approach, which improves the bowel length and reach into the pelvis. The right pararectal fold is incised and the dissection is carried along the course of the superior rectal artery. The right hypogastric nerve and eventually the left hypogastric nerves are defined and preserved as the dissection continues along the presacral TME plane. The rectal branches of the hypogastric nerve are selectively divided under the firefly mode for an optimal outcome. As the lymphatic channels along the superior rectal artery can be appreciated, dissection continues in the caudocranial direction along the superior rectal artery, ensuring a complete lymphadenectomy of the entire draining lymph node basin. It is not uncommon to have an aberrant lymphatic channel and lymph nodes beyond the confinement of the standard lymphadenectomy boundaries, as in this case. We can appreciate the fluorescent node station 16B2 at the bifurcation of the aorta, for which the extent of lymphadenectomy was individualized under fluorescence guidance. The lymphatic channel were clipped and divided and station 16B2 lymph nodes were harvested by berry picking technique. Lymph node station 253 at the IMA root was cleared under fluorescence guidance to be affirmative of a complete lymphadenectomy. Dissection of fluorescent node station 16B1 is also demonstrated here. The IMA is skeletonized and high ligation is performed subsequently. We can appreciate the clearance of lymph node station 16B2 starting from the origin of the IMA to the bifurcation of aorta with the preserved nerve plexus. Descending and sigmoid colon are mobilized along the medial and lateral aspect. Lateral attachments of the colon are released up to the splenic flexure and the gastrocolic ligament is divided. Rectum is mobilized in the presacral TME plane, safeguarding the parasympathetic nerves. The thickened presacral fascia is excised to achieve a negative CRM. Anterior and anterolateral dissection is started by incising the bilateral ovarian ligaments, the infundibulopelvic ligament, and the round ligament. The uterine artery is delineated, coagulated, and divided. Utrovesical, vesicocervical, and vesicovaginal fascia are dissected free from the bladder. Type 1 hysterectomy is performed. A circumferential colpotomy is made, following which the dissection continues along the rectovaginal septum anteriorly without reaching the denonvillous fascia. Later, the dissection proceeds along the anterolateral direction up to the pelvic floor. We can appreciate the dissection along the left anterolateral aspect. Anterior dissection continues up to the endopelvic fascia. Dissection in the deep pelvis should be done diligently, more so in a narrow pelvis with a bulky mesorectum, with care not to injure the rectum. Hiatal ligament is divided and the dissection is continued caudally along the pelvic floor. The medial fibers of the levator ani mark the entry into the intersphincteric space. The rectum is staple transected with adequate distal resection margin, and the proximal colon mesentery is divided along the IMA to harvest the apical and the intermediate nodes. An enterotomy is made with energy device, following which the anvil is placed into the abdominal cavity transvaginally. The anvil is introduced into the previously cited enterotomy and brought out through the side wall of the proximal colon at a desirable distance. The anvil is secured with an endoloop. The proximal colon is divided with an endo-GIA stapler with adequate margin. The specimen is retrieved transvaginally over a wound protector. Colonic perfusion is confirmed under fluorescence. An end-to-side double-staple coloanal anastomosis is achieved. The patient had an uneven full postoperative course and was discharged on day 6. We can appreciate the completeness and quality of TME in this specimen photography. Histopathology showed a poorly differentiated adenocarcinoma PT3N2B with distal resection margin of 4 mm and a circumferential resection margin of 3 mm.